40-year-old male, general manager by occupation, case of left side post-traumatic stiff knee with 10 degrees of extension lag with fixed immobile patella with a palpable defect at the patellar tendon with medial compartment arthritis and quadriceps wasting with implant in situ with nil distal neurovascular deficit, currently disabled with difficulty in walking and pain in the knee region.
So your main diagnosis is stiffness
Yes, sir.
associated with
medial compartment arthritis with immobile patella and defect at the patellar tendon.
now you are actually creating confusion. Now one side you are telling stiffness. Now again you are mixing the stiffness with arthritis. It is difficult to mix two words. Okay. Associated problem can be others. So whether the arthritis is causing the stiffness or stiffness, what could be the reason? Now again,
Patient had a history of earlier presented by stiffness. Patient history of from RTA in 2021, followed by which there was a compound wound on the anterior aspect of the knee, for which external fixator was done. 3 months later, the external fixator was removed, and finally plating was done on the around the leg region. Following that, patient noticed difficulty in moving the left knee.
It is a post-traumatic stiffness. One word is enough. Now don't mix the one. Don't when we ask arthritis part, then later on. So the simple say this is the post-traumatic stiffness of the knee joint. The trauma can be whatever the.
Was the fixator joint spanning or?
It was a knee spanning fixator with 2 pins in the thigh and 2 pins in the leg region.
Right.
With knee cap in extension.
Proceed. Then what happened?
Then following that, patient noticed the stiffness in the knee after plating was done, and the physiotherapy was done for around 3 to 4 months with no relief in the with no improvement in the range of motion. Patient also gives history of some wiring done around the knee, which was removed 3 months later. And after that, I guess the patient was made to walk partial weight bearing with walker. And then
Wiring around the knee means around patella.
on history could not specifically elicit, but there's a scar around the medial aspect of the patella.
No, wiring, he must have told you where the wiring is. They see the x-rays.
Yes, sir. He says
Then you can
around the
say
patella
na.
it was.
So there's how you know? Because patient told me she's seeing the x-rays every day. They tell us also na, nahi juda hai, jud raha hai. They tell us also. Yeah.
The patient currently is unable to bend the knee more than 10 degrees, and I would like to go ahead with my examination. On inspection, there is multiple scars around the knee joint with a anterolateral scar around 16 centimeters extending from the proximal aspect of tibia to the lateral aspect of the leg, healed by primary intention. And there's a scar on the medial aspect of the patella, 5 by 1 centimeter, which is also healed by primary intention, and multiple small scars healed by secondary intention present. There is examination. The patella is immobile, fixed, and there is a palpable defect on the patellar tendon, which is around with medial joint line tenderness present. There is around the range of motion of the knee is 0 to 10 degrees.
Deformity of the foot and ankle.
So there is no deformity in the foot or ankle region. Ipsilateral ankle joint and hip joint examination is normal. The range of motion at the knee is 0 to 10 degrees of flexion, which is painful with a firm endpoint with 10 degrees of extension lag. With around normal knee joint range of motion is 0 to 140 degrees. With there is wasting of quadriceps around 4 centimeters.
Any shortening?
No, sir, no shortening. The segmental lengths on both the sides were equal, sir.
So any implant is felt?
There is a history. A patient gives history of a plate which is around present in the lateral aspect of the leg, which also correlates with the scar which is present on the anterolateral aspect of the knee.
Okay, and on the patella, what you feel?
Patella,
Is there wire felt?
Patella wiring was done, but it was removed 1 month ago. So I could not palpate any implant around the region. The contour of the patella is irregular, thickened, with a palpable patellar defect, tendon defect in the
Show me the tendon defect you said now.
Palpating the patella from the distal aspect, the distal pole of the patella going downward. I could palpate the patellar tendon on the other side, but a palpable defect is there on the left side.
So ask him to do SLR.
We could,
On the left.
SLR is not present, sir, on the left side.
No, can he do or not?
Not present. Active
Sure.
SLR can be done.
पाँव उठा सकते हैं ऊपर? बिल्कुल नहीं. Okay.
Why
10
can
degrees
he
of
not do
extension.
No, why
that?
I am saying, because is there a patellar tendon in continuity or not there at all?
In continuity, sir.
No?
Not in continuity.
Why can he not lift the left hip?
If you, ma'am, if you support his knee and ankle, then he can perform, he can flex the hip joint. But because of pain mainly, he
Is the
cannot
problem at the knee or the hip?
he cannot live because of pain at the knee joints, ma'am.
See, he has some problem at the hip because even if you
Yes.
don't have extension, you can still do this. Okay, he can't do that also. So if a patient doesn't have active SLR, then what is the problem?
It could be problem could be either the hip joint, the restriction of hip joint, or weakness of the flexors of the hip.
Yeah, so it could be at the hip or the knee. Okay, if the patient has a problem only at the knee, then what will happen when he does an active
Then
SLR?
the heel will glide along the bed and the knee joint will be flexed.
Correct. So there will be an extension lag at the knee, but he will still be able to bend the leg at the hip. If the patient is not able to bend the leg at the hip also,
Hip is
then
involved?
there is some problem at the hip which
Patient gives history of surgery done in the left hip joint 7 months ago, with correlating with a scar on the lateral aspect of the thigh, curving posteriorly. But there is no on passive range of motion. The passive range of motion 0 to 90 degrees at the hip with knee in extension, and the rotations.
But
and
what
the-
was it for, that operation?
During the previous history of RT only,
Ah.
patient had some injury to the hip, which was managed later on 2 months following trauma.
Sorry, what?
Patient gives history of injury to the hip during RTA, which
Ah.
was managed 2 months following trauma. Some plating was done in the hip region.
Okay.
The passive range of motion at the hip is 0 to 90 degrees of flexion with no restriction of the coronal plane or sagittal plane.
Okay, so what do you want to do?
I would
He's
like
come
to-
basically for stiff knee, not for the hip.
Yes, sir.
Okay.
I would like to first get an X-ray done of the
Hmm.
left side knee joint with full length tibia, AP and lateral.
But what is the cause of stiffness you feel?
Most likely appears to be intra-articular on examination because the patella is fixed and immobile
Hmm.
with palpable patellar tendon defect. Also, there is tenderness at the medial joint line, which could aggravate the stiffness.
And he has got a scar on the lateral side.
Yes.
So what are the surgery done?
Most likely could be a proximal tibia fracture,
Ah.
which would have been managed by plating.
And there is no medial plating. That means on the lateral side only.
Also, the patellar wiring was done, so could be involvement of the patellofemoral joint as well.
Either one minute. How you don't find many cases of rupture of the patellar tendon with intra-articular fracture of the distal of the tibial head. Mostly what happens, it is a comminuted fracture of the tibial head with maybe Schwarzschild type 6. Along with that, there is the avulsion of the tibial tuberosity. That is quite common. In which case you have to fix the tibial tuberosity as well. Whereas he's got scar, where was he operated? In a big hospital teaching or some?
Private
Oh.
hospital outside, sir.
Yeah, so on that side, we can't say, because if it was both the condyles of the tibia, don't look up, both the condyles of the tibia, then medial plating also has to be done, lateral plating has to be done, and fixation of the tibial tuberosity fragment with patella also.
So this is the X-ray, the first X-ray of the patient, and with the wire.
No, before plating of this thing, does he have X-ray?
No, sir, not before. We don't have the X-ray with the injury. This is the post-surgery X-ray, and this is the current X-ray now.
Okay, so that previous X-ray, please put.
Yes, sir.
So what is that wire doing around with the tibia?
So the wire is
Ah.
encircling around the superior aspect of the patella.
Ah.
It is going distally through the cortex of the tibia.
Ah.
Most likely looks like an attempt to recreate the extensor apparatus of the patient, because the distal
Ah.
patellar pole is not visible
Huh.
and the shadow of the patellar tendon is also not seen.
So maybe they have sutured the patellar tendon as you were thinking, and fracture of patella is not there, na? Is it?
Patella distal as half appears to be missing.
There is a fracture, but
Excised.
Yes.
Ah.
the distal fragment is not visible.
Oh. So they have excised that patella and then they put a tension band.
This is the first X-ray. This is the current X-ray of the patient.
The X-ray of the left side knee equilateral with proximal tibia showing with an implant in situ on the anterolateral aspect with visible medial joint space narrowing and lateral joint space narrowing with distal aspect of the patella not seen and patella tendon shadow not appreciated.
So his main problem is in the tibial head or in the patella and patella tendon.
Most likely there is evidence of tricompartmental arthritis and absence of extensor apparatus as well.
There's arthritis. Yeah, but the tibial plateau looks quite okay. It has been raised and it is quite.
What investigation will you ask for to know
I would like
for your
to
management?
get an MRI with metal artifact reducing sequence to elicit the soft tissue.
And anything else you would ask for in the MRI? Specifically, you tell him.
We
You
can
tell
have
him to do a cartilage sequence.
gradient
also,
echo sequence as well for cartilage
sequence, 1
elicit.
mm, so that you want to know
Yes.
exactly whether he is arthritic because he's a young guy. So a plan of management would differ depending on the cartilage sequence.
Yes,
So you would ask for a cartilage sequence.
Fracture is united
yes, sir. There is no tenderness at the fracture
Ah.
site.
We don't have the
Mobility as
MRI.
and
We don't have the
plateau
MRI.
is good. Plateau in epilateral. It looks good, I think.
Yes, sir. Yes.
So that part is over now. The tibial head part is over. Now main thing is that the patella has been excised. There's just a proximal pole of patella and the tendon is probably not there. So that is the cause of the stiffness. So what you want to do? And the hip, what they've done for the hip?
On the hip, there appears to be a plating done on the posterior aspect of the acetabulum with two cancellous screws passed in the petrochantric region, probably indicating a posterior column acetabulum fracture and transcervical neck of femur fracture could have been there.
So that is good now. This is a recent X-ray.
Yes, sir. This is a recent X-ray. The joint appears to be congruous with no evidence of arthritis.
And that was done how many months ago?
It was done around 6 months ago.
So we don't know whether that will be vascular or what, but hip is not the presentation case over here. It is a knee. So what you want to do for the knee? Itara bata do, thoda, bata.
Or if the MRI shows normal cartilage, or do you expect something normal in this patient? The cartilage,
I would expect arthritic changes.
arthritic. Now, depending on the arthritic changes, what would you like to offer him?
Since if the patient actually wants a painless, mobile, stable knee joint, but since the extensor mechanism is not intact, I cannot offer him arthroplasty. So I would
Offer him what?
arthroplasty.
Huh.
So I would either give him option of an arthrodesis, which will give him stable painless hip, but the joint motion knee, sir,
also there.
and
Sinus is there.
no active discharging sinus.
पानी आता है क्या? नहीं आता है. पूरा बंद हो गया. हाँ, ठीक है. Good. हाँ, arthrodesis.
I would like to offer him arthrodesis for the knee joint, which will be done in 10 degrees.
Both are good. He's having a lot of pain. He wants a painless, but with the painless, you will have a fixed knee. You cannot not have a painless mobile knee in this patient.
Yes, sir.
Because there are too many issues to be resolved. Then you'll end up doing a lot of jugglery for it.
वो नहीं आता है. So your this thing is knee arthrodesis because the patellar tendon is not there at all.
How do you, what will you use for knee arthrodesis? What was used? What are the implants you can use for knee?
Knee arthrodesis can be done with an internal fixation via an intramedullary nail or via external fixation using Ilizaro, or I could use a plate as well. But since the skin condition is not good, I would like to go for Ilizaro or intramedullary nail.
Previously, there was an implant used for knee arthrodesis. Can you elaborate for
Yeah.
the benefit of people?
Do you know any other implant?
Any
Yeah.
other implant
In the
you can use very
in the audience? Yeah.
Many of the people use it in many centers where
Yeah.
they are not equipped with Ilizaro.
Named after.
Popularized by, sir.
So many times we have used it. What is the clamps called as? Chanley's clamps. And Chanley described trabeculae going from the femur into the tibia. After how many weeks of Chanley's clamp? 4 weeks. 4 weeks. In 4 weeks, he found that the trabeculae are crossing from the femur into the tibia. But here, probably because there are so many holes of that plate, you can't use the Chanley's clamps. Okay, so Ilizaro.
Ilizaro,
So you
be
can
my
walk
choice.
also in Charlie's car, you can't make him walk because it's not a load bearing device. The pins and all will break. But with the Ilizaro, you
You
can
can wait there.
wait by that.
Yeah, that's right. With the hip involvement and with the wasting of the quadriceps and the tendon absent, any other form of surgery except for knee arthrodesis, I think is not feasible in this patient. So on that point, yes. Okay, good.
Thank you. Thank you,
Good
Dr.
presentation.
Ronak.
So next case.